Welcome for the very first time into the Radiopaedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. It is but a humble radiology podcast. My name is Andrew Dixon, and joining me, as he has promised to do every episode, is my co-host, Frank Gaillard.
I have promised no such thing. I promise to attempt to be here sometimes, and provided you, as usual, do all of the work and I can just turn up.
I'm hoping we don't have to do very much work. I click record and then upload. That's the plan. Minimal editing. I actually remember reading the number one tip for starting a podcast was to record your first 3 episodes and then to throw them in the bin and start over because they'll almost certainly be terrible. It's probably good advice, but we're not going to take it because we haven't got time for that. How have you been, Frank?
I've been pretty good. Getting over the January school holidays, which are always, I love the fact that I get to spend time with my boys and my wife, although she's been working a lot. But it is pretty challenging to find time to do any work. And balancing holidays is an ongoing stressful thing for me. I haven't quite worked out the knack. Maybe by the time the boys are too old and don't want to spend time with me, it won't be an issue, I suppose.
That's the worry, isn't it? By the time they're ready to move on and you're like, hey, let's do a holiday. We probably should introduce how this podcast is going to work. So recently I realized that we record a whole bunch of panel discussions with amazing speakers from around the world for our annual virtual conference. And afterwards, they're essentially lost. They disappear, as opposed to the conference lectures themselves, which remain in our lecture collections. So I thought, how about we repackage these discussions into a podcast for everyone to enjoy? So that's what we're going to do. Some episodes are going to be clinical radiology discussion, like today's episode, while others will cover some non-clinical aspects of radiology. We'll hear a lot of different voices from around the world, lots of different perspectives, with the common theme being radiology. And if we have the time and energy, Frank, I think we might also try and record a few little extra things here and there, won't we?
I think that would be really good. There's so many people around that I'd love to have the excuse to talk to, and we never seem to find the time to do that. Some of those people are editors from Radiopaedia, others are colleagues from our own workplaces. There's people that we've met around the years or even never met but want to have the excuse to talk to. So hopefully, if you can do your side of it, which is all of it, we can use that as an opportunity.
This came about in part because one of our friends of Radiopaedia was suggesting that we should start doing some TikToks and things like that. I had a look at TikTok and I was like, this is not for me. And I actually had a few people at work going, Andrew, you'd be really good at TikTok. And I'm like, no. Podcast is probably a better fit. And if I can drag Gaillard into it, it'll probably be pretty entertaining. So
anything that doesn't have video that needs to be edited should be much
absolutely
easier.
That's what I'm hoping anyway. So for today's episode, we're going back to a head and neck panel discussion that I recorded with Christine Glastonbury and Jennifer Gillespie at Radiopaedia 2021. I've chosen this one because I think it's the very first panel that I ever hosted, and both the guests are absolutely delightful. For context, this took place immediately after Christine's lecture on oral cavity tumours and Jen's lecture on imaging of the post-operative neck. Both lectures can actually be found in our head and neck lecture collection on the website. However, this discussion should largely make sense on its own. In fact, listening to the panel and then, if interested, going back and watching the lectures might actually be a fun and different or efficient way of doing it as well. All right, so let's get into it. Let's have a listen to this panel discussion with Christine Glastonbury and Jennifer Gillespie, and then afterwards, Frank and I will be back for a little bit more of a chat. It's now my pleasure to welcome the two speakers we have just seen, Christine Glastonbury from UCSF and Jennifer Gillespie from Royal Brisbane and Women's Hospital for a quick panel discussion. So welcome to both of you. Fantastic talks, as always. Christine, interactive. You had me fingering my retromolar trigone in no time. So I guess that's a good thing. At one point, Christine, you actually asked people to take a selfie of your floor of mouth and email it to you. So if anyone's watching, Christine, what's your email address?
Christine.glastonbury@ucsf.edu. I'd like to have a collage of everybody's
That'd be
floor
good.
of mouth.
We'll tweet that out, a collage of floor of mouth selfies. So I've got some questions based on both of your talks, and we'll kind of just go through those, but very happy to discuss anything you guys want to discuss. So I'll start with you, Christine. A lot of what we were looking at in your talk with oral cavity tumours, and in fact in Jen's talk as well with tumour recurrence, the imaging findings were very subtle, right? And I guess my first question to you, Christine, would be, is there anything that we can do as radiologists to actually make our job easier, or is it always super hard in this area?
So I think it's such a great question, Andrew, because I think one of the hardest things I think with teaching head and neck is people are afraid of head and neck because it seems hard and some of the findings are subtle. But I think one of the reasons I like teaching it and why I really just love doing head and neck is that there are a few secrets. And that's really what I try to do in my lectures is share the secrets. And I think if you learn a couple of the tricks, like, for example, when you see a dilated submandibular gland, a duct of a submandibular gland, that's a key that there may be a tumor in the floor of mouth. Little things like that. And once you start looking at a lot of head and neck scans, you start to see this pattern that they're kind of, the squamous cell carcinoma is the most common tumor, but it's like one histology. So it's pretty predictable behavior. So it seems really hard because there's a lot of anatomy. But really, it's just a matter of learning a few tricks and then really just looking at scan after scan.
I saw a fair bit of knowing the normal kind of thickness of the muscles in that area, the buccinator muscle, for example, and looking at the fat planes, right? Looking for displacement or effacement of fat. Is that what you kind of look for, Jen?
Yeah, and I think just looking at lots of normal scans so that you get an idea of what normal is supposed to be. A lot of practice, but a lot of knowing the anatomy, really.
And Jen talks about this in her lecture. Knowing like the history changes everything. Really, I would make every mistake in the book if I just looked at head and neck scans and didn't have some history of, for example, like I talk about an oral cavity. Some of them are almost impossible to see. Yes. A lot of glottic tumors you can't really see, but your job is not so much to find the primary. It's really more of looking for the deep invasion and involvement of the bone or perineural tumor spread or looking for lymph nodes. So you kind of have to have some history, but looking at a lot of scans, getting really comfortable with anatomy is critical.
Jen, you actually mentioned in your talk, your process that you actually, kind of dig up the pathology reports and things like that. Can you go into a bit more detail? Like what do you actually do and how much time does it take?
Yeah, well, that's the trick, isn't it? It takes so much time to do this, but there's such difficult scans that anything that you can use to make it easier is always helpful. So we have the IMR linked to our pack, so I can just open up the patient's record, look at the operative notes, look at the pathology. So I always look at those, always the old scans, because it's so helpful to know exactly where the tumour was to start with so that you can look where it's possibly going to recur.
And this is why I guess it's really hard in private practice as well when you're kind of seeing a scan and they've had surgery, you can see the neck dissection there, but you haven't got the information and you've also got time pressure. You haven't got the time to be digging up all that stuff. And so you can kind of understand as, people who work in academic institutions have a little bit more time to look at things, why some of the reports you might see from outside might not be to the quality that you'd want, and it's it is hard. Christine, at
this
one
is
point,
why I do academics. I'm a chicken.
To have a little bit more time. At one point, you very deliberately stated that the tumour didn't show any evidence of perineal invasion on pathology or perineal tumour spread on imaging. This is actually something that is covered in the next lecture by Carter, and I think Jen mentioned it as well, and something that she looks for in pathology reports is perineal invasion. But I wonder if you, for the benefit of people who are watching who may not have ever considered the distinction between those two terms, what they actually mean.
Absolutely. Great question, Andrew. You were listening. You were really listening.
We all were.
P&I is a histological finding of tumor invasion in, around, and through nerves. So it's true histological finding. And it's really distinct from perineal tumor spread. So perineal tumor spread is a macroscopic tumor extension along a nerve from the primary tumor. And that it may either be clinically apparent or radiologically apparent. So PNI, which is that histological invasion, worsens the prognosis of all patients, and particularly those who have close surgical margins. And it's very much associated with an increased risk of regional recurrence. So there's a lot of data on that. And so I know Jen mentions it in her lecture that she looks at the report to see if there's PNI, because this is, if you have a tumor that has PNI and histology, this is one you're going to be really worried about recurring locally, particularly, and in lymph nodes. So by comparison, perineal tumor spread that you and I are looking for on the imaging scan is actually not associated with a greater risk of regional metastasis, but the morbidity can be severe. And so when you're planning radiation fields, and I get to do that with my radiation oncologists, you're looking to see if it's spreading, and they will sometimes preemptively radiate those nerves because it will result in symptoms. If they have, gross perineal tumor spread, they'll have pain, they can have numbness, other sensory nerve dysfunctions. And of course, it's how it goes along the nerve to access the brain. And you don't want to have perineal tumor spread getting near the brain. It's really hard to get rid of. So the PNI is an indicator that this is a tumor that has a high risk of local recurrence. And so when Jen's reading that and I'm reading that, you're thinking, this is one I'm more worried about than others for recurring locally. So on follow-ups, I'm really looking carefully to make sure it's not locally recurring. But perineal tumor spread is that macroscopic appearance that we see on imaging.
Yeah. Jen, back to you. We saw quite a few cases of tumor recurrence where there was PET really clearly showing that there was recurrent disease and nodal spread, but it was quite tough on the CT alone to spot them. And it kind of begs the question, why do we not use PET as the primary imaging modality to follow up these patients? And then I guess, Christine, if you could give your perspective of how PET is used in the United States, because it might be a bit different here in Australia. So, Jen?
Well, I guess if we had unlimited resources and all the money in the world, we would be doing PETs on everybody. Obviously, there's a different way that we fund imaging in Australia compared to the States. And I think a lot of places, it's also about accessibility of imaging modalities. So certainly we would do a PET for most of our cases in the first instance of their first post-operative imaging, but then go to CT following that if the PET was clear. A lot of our patients come from a long way away. So we have patients in Queensland who would have to travel 12 hours by car to get to their nearest PET scanner. So, it's a bit about accessibility. So people are going to go and choose the CT rather than the PET scan. But ideally, PET everybody.
Yes. And Christine, what's it like in the US for access to PET versus CT for following up these patients?
Well, I have kind of two things. One is I have very mixed feelings about PET.
Yeah.
Because there are a lot of false positives. And there's also different types of PETs. People do PET and they do a nice contrast enhanced CT, which for me is essential in the head and neck. If you don't have a good quality contrast enhanced CT, I think you're wasting your time most of the time because of all the false positives and false negatives that happen.
And a lot of those complications that we saw in Jen's talk, not going to spot them on the PET, are you? That's right. You need contrast CT to spot a lot of those things.
Right. So and a lot of places will charge, same price, and they'll do a CT. And I usually describe we get a lot of those from patients having them done on the outside, and the CT looks like it was shot from space, like it's this little small field of view. There's no contrast. And I'm like, well, there's something there. It's in Jen's lecture, she shows some beautiful cases where she has a contrast enhanced CT. And when you put the PET with it, you're like, yeah, obvious. But without the good CT, it's a waste of time. So the US, when it comes to healthcare, is a complete disaster. So this is
all I wanted to hear. That's the main reason I asked the question.
More is not better. And having access depends on how much money you have and health insurance. And it's really, the less said about that, the better, I think. It's very difficult. I have to tell you, that's one of the toughest things is, I trained in Australia. Everybody has great access to what you really need. People here go broke and they don't even necessarily get what they really need. It's really hard. Having said that, if you have access to things, a lot of people do get PET. And a classic after chemo radiation, for example, or after surgical resection and radiation, we'll get a baseline scan, either MR if it's an oropharyngeal tumor, or most of the head and neck, the oral cavities, for example, they will get a CT as a baseline, usually at 8 weeks, and then a 3-month baseline PET. And where it goes from there, whether it's just CT or whether it's going to be a PET CT, will largely depend on if that study is really good. If that study is really good, usually we will just continue with that modality, and we won't use PET until we see there's gross recurrence, and now we're looking for metastatic spread, and what are we going to do for here? The difference is with nasopharyngeal carcinoma, which has a much greater tendency for metastatic disease at presentation, and we're more likely to follow with PET. But by and large, it depends what your insurance company is and how much money you have in the United States.
Yeah, it's sad, isn't it? I guess from a CT interpretation point of view, it's really looking for quite subtle changes and comparing with the prior scan, but also the one before that and the one before that, to look for things that might be growing slowly or happening slowly. I just have written down some key takeaway points that I've taken from your talks, and I'm just going to kind of speak them to you, and you can feel free to just nod along. You don't need to respond verbally. You can just, feel the appreciation for the things that I've taken away from your talk. If you want to interject and clarify anything, then feel free. So for Christine's talk, I've written down that tip about using gauze for the puffed out cheek view on MRI, because a patient can't really do that for very long in an MRI scanner.
Works really nicely.
Does it?
It's really easy. We read a paper on it, I don't know how many, 15 years ago. It's really easy. ENT surgeon gives them the gauze. They bring it to their appointment and they put it in just before they go into the magnet. And it just looks black. But it pushes the cheek away from the tumor.
But even like leaving the dentures in looked like it was quite useful for some of those tumours as well, right? If you took the dentures out, you're kind of losing a bit of separation between.
I know. Things. Isn't that fascinating?
Yeah.
No one's ever written about that or done that. But I was looking at it on CTs. I was like, that kind of helps. Good observation.
Your point about the hard palate kind of being different to the rest of the oral cavity in terms of the tumours that arise there. I see this all the time. Every time I give a hard palate tumour case to one of our trainees, the first thing they say is always SCC, and minor salivary gland tumours may not even come up in their differential, even if there's, obvious tumour spreading up the greater palatine canal or something. So I think it's just worth re-emphasising that you're really talking about minor salivary tumours there, and to have a great look at that greater palatine canal for perineal spread up into the pterygopalatine fossa. The next thing I've written down is the gingival SCC goes to the bone, and so look at CT in particular for cortical erosion. So get a CT if you haven't got one, and then if it is going to the bone, that's going to change your surgery, obviously, because you're going to have to do a mandibulectomy. And
so always get bone algorithm, not just soft tissue algorithm, because you're really looking for that cortical erosion for the marginal mandibulectomies.
The next thing I've written here is what we already discussed, the obstructed submandibular gland as a clue to the floor of mouth tumour. That's interesting because I think that presents often with ultrasound, right? You're doing an ultrasound for a swollen submandibular gland, you see some dilated ducts, and I just wonder how often, whether I should be more often kind of looking for a small tumour and whether I should be going towards doing an MRI to look for that, or do you think...
get the patient to do a selfie of the floor of their mouth.
Maybe that's the thing. You need to actually, maybe put that in your report. Correlation with any appearance in the floor of the mouth of a tumour would be recommended. The next thing I've written here is the imaging thickness of the tumours that we see does not equal the depth of invasion. So the pathologist is going to tell us what the depth is. If you've got a big exophytic tumour, then that might not be representative when you actually do the pathology. And so our job is more to map the tumour. I thought you described that well. Kind of, the pathologist isn't going to tell them necessarily where it's going. We're going to be able to map it, and then from there you can predict where it's going to potentially spread to and how much surgery the surgeon needs to do. So that's what I took away from your talk.
Perfect.
Christine.
That was great. I didn't even... Now they don't need to listen to the lecture. You can just list it out. It's perfect.
And Jenny, from your talk, a few things that I took away: atrophy of lymphoid tissue occurring post radiotherapy. I hadn't thought about that before, and then confusing that kind of contralateral, palatine tonsil that we often see that lymphoid tissue there for being contralateral disease, because it looks very asymmetric, and that's what you're trained to look for, and suddenly you go, oh, look at this big lump over here. So I thought that was a really good point. The muscle flap versus graft, the differentiation between those. Some of my trainees could definitely do with watching that part of the talk. But also the muscle flap should maintain that kind of muscle appearance. Like, it's a muscle, it's going to become atrophic, but it's still going to have that kind of striated appearance to it on the follow-up images. And then the other point you made is that kind of any increase in volume of that flap over time is suspicious. So if anything, it should get smaller, right?
Yeah. And I think one of the things with the flap is that you tend to look right in the middle of where the operation was, but it's really key to look around the edges as well, because, the edge of where the surgery is often where you can recur.
And then the final one I've written down here is residual thyroid post the, pharyngolaryngectomy. You've taken out one side of the thyroid, the other thyroid's still there, but because of the distortion of the, the neotrachea that you've kind of put in there, you get this kind of rounded appearance to the remaining hemithyroid, and that can be confused for a lymph node. So I thought that was really good because, again, you're just looking for that typical thyroid shape, and if you don't see it, anything round you normally automatically think is bad, right? So it's just worth keeping in the back of your mind.
Those are all great points. Jen's lecture is fantastic. You notice I got the easier lecture here. But no, they are great points. I've seen a number of those thyroids being biopsied. And that asymmetric lymphoid tissue, that's a huge thing on PET as well.
I was going to say that's a nice false positive on PET.
Great false positive. Side. Yeah. And when they take out the submandibular gland on one side, just as a selective neck dissection, and the other one gets called a mass on PET because there's, some mild FDG uptake in a normal submandibular gland, and it looks like a mass because it's asymmetric.
Or a palpable node for the clinicians. Like often they feel the submandibular gland and think it's a node.
Yeah.
We're so built for the symmetry, aren't we? So thank you both again for your fantastic lectures, and also just for your support of the conference and for Radiopaedia in general. I know, Christine, in particular, you've always been very supportive of what we've been doing, and I'm very thankful for that. I hope you enjoy the rest of the conference, both of you. And we're going to continue this advanced head and neck session now with a lecture from Carter Kavanagh. She lives just a few hundred metres that way. And that's on perineural tumour spread and the skull base. And then I'll be back at the end of the session to show a few live cases. So stick around for that. And Christine and Jen, thanks again, and bye for now. See you later.
Thanks so much, Andrew. Bye. Good to see you both.
Great to see you too. See ya. Bye. I told you they were delightful people, didn't I? That was fantastic to listen back to that panel discussion from 2021. Frank, did you enjoy that?
I love it. And I love hearing how the Australian accent tries desperately to remain despite many years.
Out of interest, have you listened to or watched either of those lectures?
I did at the time. I didn't rewatch them now, I have to admit.
So you still think, out of context, without having seen the lectures, the panel discussion, you can follow along?
Yeah, absolutely. I think, in fact, it gives a lot of grounding. And were you to go back to the lectures now, I think it would be a different experience. I think that'd be an interesting way of doing it, listening to this and then going back to the lecture, even if it's to revisit it, I think.
So that's one thing I'm hoping from this podcast series, that people can listen to these panel discussions and then maybe go back and rediscover the lectures. As I was listening, I realized that I mentioned the graft versus flap thing from Jen's lecture in the panel discussion, but I didn't actually restate the distinction between the two. So that could have caused some confusion. So we probably should clear that up. Frank, do you know the difference between the two?
Well, there's not too many grafts or flaps in the brain, so I can't say I do this very much. But isn't it a graft is devascularized or doesn't have a blood supply, whereas a flap is on a vascular pedicle, like a free flap?
Yeah. So like a graft is like a skin graft that you put on a scalp defect. It needs to grow its own blood supply once you put it there. Whereas a flap, comes with its own blood supply. So you might take a free flap from the forearm, a radial free flap, take its own artery, place it somewhere else in the body. You can create local flaps or even regional flaps like a pectoralis flap. You can reflect that up into the neck. So the difference is, very much one of blood supply.
Did you know, this is a bit of trivia, but the idea of an angiosome, the piece of tissue that is supplied by an artery, which is predictable and forms the basis of these vascular free flaps, where by taking an artery and the tissue that it supplies, you can then move the whole thing and with relative safety that it will remain vascularized when you anastomose that artery. That idea, the idea of an angiosome, was first described by a plastic surgeon from my hospital, Jeffrey Ian Taylor. I think he always goes by the name of Ian Taylor. And he did these amazing dissections of fresh cadavers where he injected ink into various perforating arteries to show how predictable the territory that was perfused is. And there's his book, which I think he used some X-ray techniques with my old boss, Brian Tress, to image it. But some of the specimens and the photos of them were, at least, at the Melbourne Museum up in one of the display areas. And they're these full body skin dissections. So it looks like a sort of man stuck up on a pinboard with all their arteries branching out in black ink. It's remarkable.
Whenever a registrar puts MCA vascular territory in a report, I'm going to say MCA angiosome is infarcted.
Yeah.
Could I do that? Or
I don't think so. I think an angiosome is for skin subcutaneous tissues. Down, I think. I'm not sure.
No,
Maybe.
I'm going to say Frank Gaillard told me to say that. We're going to finish off by telling people how they can get in contact with us, or you're going to do that.
Well, we are at Radiopaedia on Twitter and Instagram. And you can also try and reach me at Frank Gaillard on Twitter, although I have to say I'm trying to steer away from the social media cesspool as much as I can, whereas you, Andrew, love to float around in there. So you're at Dr. Andrew Dixon. You can also email us at podcast@radiopaedia.org with any ideas or feedback. And we're expecting quite a lot of feedback. Hopefully some of it will be good. If you want to help support us, then Radiopaedia, you can become a supporter, or you can, of course, get an all-access pass to access all our content. And, of course, that also gets you registration to our yearly conference, which we're in full swing of preparing for Radiopaedia 2023.
Coming up July 24 to 28.
And I have to say this next thing, because all the serious podcasters say it, and we're desperate to fit in. You can help us by leaving a review of this podcast on your favorite app.
On your podcast app of choice. Well, that's it. Thank you, Frank. That's episode 1, all done and dusted.
Thanks, Andrew.
And I'll see you again next time. And I've got a sign off here. I asked ChatGPT to write a sign off for us. Some of its ideas that I'm not going with. Keep reading, stay rad. Maybe not.
That's probably for TikTok.
Read on, radiologists. Sounds like a Star Trek kind of one. Read well, radiologists. Stay informed. Stay reading. That's pretty good. Okay. But I think I'll go with we'll catch you all again sometime soon in the reading room.